And we looked at the other eye. There was an empty socket. What had happened there? A cataract surgery in the other eye done 6 months earlier had developed a keratitis and then had to be eviscerated. So that gives you a clue as to what's going on. There was a history of irritation and foreign body sensation in this patient even prior to the cataract surgery. So on digging further, there was a history of multiple joint pains involving the small joints of the hands 2 years ago. It's not taking any medicines. Also a dry mouth since a few years. So we're looking at probably a Sjogren's syndrome. The RA factor was through the roof, as was the ESR, which was high. And so a diagnosis of a rheumatoid arthritis with a sterile corneal melt with dry eye was made. And 3 months later, with appropriate antimetabolite treatment with methotrexate, folic acid, and topical lubrication, the vision had stabilized at 636 with some corneal scarring and pigmentation. Another scenario with a 55-year-old lady with pain and watering for a month with an epithelial defect and what appears to be an active scleritis with corneal thinning and a scar. Did the investigations, and the C ANCA was high. And the ANCA, as we all know, they are serum antibodies against neutrophils and monocytes. And these titers tend to parallel the extent and severity of Wegener's granulomatosis, and they correlate with the state of the disease. And in this patient, the appropriate treatments of immunosuppression were added, and you could see the scleritis resolving with that. 4 months later, there was a vascularized corneal scar, and a plan of phaco was made with the scleral temporal incision under steroid cover, and see what happened at the site where the phaco incision was made. There was a melt even there. So even with well-controlled conditions, you can have these kind of problems where any trauma can then lead to a melt in that area, and a scleral incision is a trauma. The diagnosis of Sjogren's syndrome may require evaluation of serum autoantibodies, including the SSA and SSB, which are Sjogren's specific, and the ANAs and the RA factors are high in all these patients, and these must be a part of the management that we do. If we look at the reflex block amongst the non-Sjogren's, we know that the absence of blinking leads to a severe dryness, and this is the nerve plexus that Dr. Rosenblatt also referred to earlier, which is in the subepithelial area. And the corneal anesthesia is really one of the most difficult forms of dry eye to treat, because when the fifth nerve is desensitized, there is a neurotrophic keratopathy which sets in, and this is just a list of some of the things that causes this ocular sensory loss. Amongst the evaporative conditions, there are intrinsic things like Meibomian Gland Dysfunction, and here's a 52-year-old gentleman who complained of persistent redness, discomfort, and watering with a history of a watering eye for the last 2 decades or so, and we could see the Meibomian gland disease. He had eruptions on the face when exposed to sunlight, and rosacea in these patients, those especially with coming in with multiple chalasia, is one of the problems, and there are various kinds of triggers such as alcohol and exposure to sun, hot beverages, etc., which cause this kind of inflammatory change in the skin. So these are some of the masquerades that are there. If one goes on, one looks at the disorders of lid aperture, and that's something that we often miss when we're looking at these dry eye patients. And is the dry eye a cause of this, or is it an effect of this? And that's something, again, in that cycle, one has to try and figure out which way it works. So this is the kind of picture one can see, and here's a patient with who has received Botox, and you can see the incomplete blinking that is happening, and this patient is bound to develop an element of dry eye because the blink reflex is not adequate and complete. If you look at extrinsic factors, here's another patient who came in with this kind of corneal picture with redness over 3 months, 36-year-old. Left eye, similar kind of a picture with a little bit of healing. Again, redness and photophobia for the last 3 months. The history of hospitalization with difficulty in swallowing food and water for a month, was diagnosed as ulcers in the esophagus and stomach. There is a history of drug abuse and alcohol. So that is something that we don't often ask these patients, but these are some of the things that one needs to look at. The VDRL was negative, the HIV was non-reactive, the ESR was high. This is the picture on the conjunctival side. Chest X-ray showed pleural effusion. He was started on anti-tubercular treatment given the scenario. The eye perforated, went in for a graft with a tarsorrhaphy with a persistent epithelial defect. But this is the slide that probably gives it away. And what is this really? Is it OCP? Is it SJS? is it a deficiency of some sort? It's actually malabsorption syndrome from a vitamin A deficiency, given that with the drug abuse and the alcohol abuse that he was undergoing. So dry eye, as we all know, is a multifactorial disease that affects the ocular surface. And there's a new definition out from last year wherein a couple of new things have been added in. And so thank you so much. So that was some of the masquerades that are there. And when we're evaluating these patients, one must have a very broad view of the patient and the holistic approach in trying to see how the environment and how the things that this patient is doing has an impact on the dry eye. Thank you so much. To request Dr. Vanathi now to give us her presentation on the conventional management.
Thank you, sir. And it's nice to be here among you all, and I thank you, Dr. Rishi, for including me in his wonderful session on ocular surface disease. And he always gives me topics in which I can't put in any pictures or videos at all. So it's going to be most of one dry. Okay, so it's the most difficult topic when we always treat dry eye patients is how do I choose the right lubricant for this particular patient? So I'll just take you in the next 7 minutes to how you would, what are the options you probably have, and what should you choose for the kind of ocular surface disease you're treating this patient. So when you look over the counter, the options are tremendous. They are quite confusing. And considering that what you have in the drops is a demulcent, is a preservative, and a buffer agent, but how you decide on what tonicity is right and what viscosity is right for these patients. So it's again a busy slide with a paradigm shift in understanding ocular surface disease and the dry eye parameters which affect the ocular surface. And you see that this is a slide which needs a lot of analysis to look into what is the pathology which is affecting your particular patient. But now we are moving down to break this into molecular mechanisms which are affecting the ocular surface. And the need to understand the molecular mechanisms is that you will have to target the kind of drops you are using to treat the patient to deal with that molecular mechanism which is affecting and causing the ocular surface disease. That is what is going to result in the success of your treatment. So what you need to understand is how is your lubricant which you're choosing going to alter the ocular surface status in terms of altering the tear instability? How is it going to tackle the hyperosmolarity? How is it going to tackle the cell surface damage which has occurred? How is it going to tackle the inflammation in the ocular surface? And how is it going to stabilize the lipid layer? So it's understanding these pathologies which will help to work in these patients. That's why we always understand what works in one perhaps does not work well in the other. Today, the tear film model has moved into a very complex molecular model, which has a very fine interaction of the lipid layer, the aqueous layer, and you have what is known as the MUC, or the membrane-associated mucins, which forms a complex glycocalyx on the ocular surface. And an integrity of these molecules is relevant in managing your ocular surface disease. So how do the molecules which are contained in your eye drops going to help to restore this normal molecular structure of the tear film is what is the secret in managing your ocular surface disease patients. There is again a shift in thinking in management of ocular surface disease. Earlier we treated the symptoms, so we waited for the dry eye to happen, and once the dry eye has happened, we moved on to a therapeutic modality. But today there is a shift and the need to treat the ocular surface by optimizing the tear film. So we are probably moving to treat an asymptomatic patient before the effects of the dry eye are mount to such an extent where it becomes difficult in reversing the molecular damage that has occurred in this patient. So as this diagram shows, you're now moving on from symptomatic management to managing an asymptomatic patient, so that the adverse effects of ocular surface disease or the dry eye disease does not set on and makes it more difficult to reverse the molecular mechanisms which have already been triggered in causing the discomfort for the patient. By and large, most of us in our practice, we know there is a significant overlap of Meibomian gland disease when you're looking at what causes the evaporative dry eye disease and the tear deficient dry eye disease. So then you'll need to use a combination of medications, and you'll have to understand what is contained in